All right, next, let's talk about our diagnostic tests. This is labs and diagnostics that we're going to do if we suspect a CT or a PE. The first one is your book refers to it as a CTPA. Usually they just say CTA. So CT scan. The P stands for pulmonary, and the A is an arteriogram, which means we are looking at the blood flow into the lungs. So they're going to do the CTA emergent. If you suspect a PE, then that patient needs to go to X-ray and have the CTA done and look and see if we can see a PE or what the problem is. Now, so that's the primary test. They could do a chest x-ray, but it's not really going to show anything. I did include what's called a VQ lung scan. Back in my day, that's a ventilation perfusion scan, where they do the scan and then they inject them with a radioisotope, and then they do it again to see where that radioisotope was, if the area that it was not taken up to, which means there's some kind of blockage. The CTA really has replaced this. However, we do still see it. I've seen it a few times, so I just wanted to stick it on there. We're going to do a venous Doppler. So think about this. What are we going to use the venous Doppler on? We're not using it on our lungs, but we're going to use it to go find, do I have more clot somewhere else? So if it came from their legs, if it came from their arms. So they're going to come in and do these venous Dopplers to see if they have clots. You may see a venous Doppler done before they actually have a PE if we are suspected of that, because what we're trying to do is go in there, see that clot before it breaks loose and causes a PE, which is a life-threatening event. They may do an EKG to rule out that this is a MI, myocardial infarction. They might even do cardiac markers, do a troponin just to make sure, because sometimes those signs and symptoms, I've already said, kind of overlap. They're going to look at coag studies. So they're going to look at a PT, a PTT, and an INR to see what those coag values are. They'll look for what's called a D-dimer. A D-dimer with a positive result that's elevated tells us we have a clot. We will talk more about D-dimers when we talk about sepsis and DIC, but certainly we can do it for this. They may get basic if they're coming into the ED, just a CBC and a chemistry, because I think those are basic lab studies we're going to do anywhere. They might also get ABGs if we're having a respiratory problem. So be sure that when you're thinking of these clinical manifestations, these tests, what are you going to do as a nurse? If my patient is tachypnic, short of breath, and has a low O2 sat, well, what are you going to do? You're going to put some oxygen on them. You're going to raise the head of the bed so that they can breathe. You're not going to let them get up and go to the bathroom because they don't have enough energy to do that. They can just use a bedpan. All of those things that you already know to do because you've already talked about gas exchange, we're going to apply to this. Collaboration. So this is, when I think of collaboration, this is your interprofessional team members. So who all needs to be on my team? So I use the term healthcare provider. Healthcare provider can be a physician, so it's an MD, a DO, it could be a nurse prac, it could be a physician assistant. Those are the people that are going to give me orders. So I like to say people with more degrees than I have. That is who we're looking at. I will have, if they're having a breathing problem, I need respiratory. I'm going to have radiologists. I might have an interventional radiologist come in. We need a pharmacist because of the medications we need. A dietitian. We may need case manager or social worker if we're having to deal with those. If we need things like insurance dealt with, if we need resources when they go home, those types of things. So when you think of your interdisciplinary team members, be sure you're thinking of the people who are most appropriate. We don't add people to the team that we don't need on the team. Okay, so let's talk about our treatments. So our first treatment is going to be anticoagulation. If they've got a clot, we need to give them anticoagulation. So we have some options. We put them on, started them on a heparin drip. When we run a heparin drip, usually you're going to give a bolus, then you're going to run that as a drip. Heparin is in units, and most of the time, this is now run in units per kilo per hour. We're adding that kilo to make sure that we are more specific to the patient. I want you to remember something. When we talk about running something on a pump, especially a continuous medication, those are called drips when we have continuous infused medications. So sometimes they're anticoagulants, sometimes they're vasoactives, work on our vessels, either vasoconstrict or vasodilate, could even be sedation. So lots of different drips depending on what kind of drip you have. You can be on the floor because somebody on the floor can be on a heparin drip, but if you're on a vasopressor to increase your blood pressure, then you cannot have that on the floor. The pump is set at a rate. That's how many mils per hour. All of these drips have a dose, and you need to know the difference. And when somebody asks you what your drip is infusing at, they want the dose. They don't want the rate. The dose is units per kilo per hour, or however your provider has ordered that for you. You have to calculate a dose, and the pump is off a rate. So be sure you have those two correctly, and when you're giving report, you report on a dose. So we can have a heparin drip. So if we're on a heparin drip, we do have to do routine coagulation studies. It may be a PTT. It could be something else. There's some newer things. It depends on your facilities. I can tell you our local facilities, they actually do two different things. And you will draw that lab. You will go to your orders in your EHR, and depending on what that lab value is, you may turn it up, you may stop it, you may turn it down, you may have to bolus them. We have a titration protocol. So regardless of what lab it is, you will have specific orders on if the lab is this is what you do, so we will follow those. Long term, these patients are going to have to go home on anticoagulation because they have a clot. So they may go home on warfarin, also known as Coumadin. And if they go home on that, we have to do our education about that, because if they go home on any type of anticoagulation, they are at risk to bleed. That doesn't mean that they can't do things. They just need to be careful and understand that if they cut themselves, they are going to bleed. And there are probably some activities they need to be very careful on doing. If they're on warfarin, they will have to come in and have monthly lab draws and get an INR drawn. You do need to know normal lab values, and normal INR is 0. Therapeutic is 2 to 2.5 times that. Apixaban. So if you don't know what apixaban is Eliquis, and we are seeing a huge amount of Eliquis being given for PEs and strokes as well. So I want you to know about apixaban. So apixaban is an anticoagulant. However, there is no lab work that we can draw to tell us how thin or not thin a patient is on Eliquis or apixaban. A PT, PTT, INR do not change with this. That is the same also for Pradaxa and Xarelto. So those are the three new ones: Eliquis, Pradaxa, Xarelto. Eliquis, apixaban, generic name. That's what you're going to see. Seems to be ordered much more frequently. We are seeing patients with PEs locally being started actually on apixaban because it gets therapeutic very quickly, and they're actually using that over a heparin drip. Doesn't matter. As an RN, it is not my job to know which med to give. It is my job to know which meds are appropriate, appropriate dosage, to administer them appropriately. So I just know that they need anticoagulation. So if they order heparin, great, I know how to deal with that. If they order apixaban, I know what to do with that. They may do a thrombolytic, and this is for life-threatening situations. And a thrombolytic is a clot buster. So the two most common is TNK or Alteplase. We're seeing TNK more. It is cheaper, faster. The half-life is shorter and it has less side effects than Alteplase. With Alteplase, you have to give a bolus and then run a drip over an hour. With TNK, it's an IV push injection that you can give right then. So they may need that. What you need to remember is if somebody is given a thrombolytic, they are going to bleed. So you do not want to be sticking this patient. So if you think that they're going to get a thrombolytic, what should you do before you administer that? You need to put any tubes and lines in that patient that they need before they get it. So they need 2 IVs, because if I'm giving these medications, they need to be in a med by themselves. So let's start 2 IVs. And this is not the time that you say, hey, I'm a student and I've never started an IV. Can I go start this IV? No, because any IV poke site, any lab draw site, any ABG site is going to bleed with these things. So this is the time that somebody who gets that IV every time starts that IV. So get 2 IVs in. If there's a need for a urinary catheter, we don't do urinary catheters and Foley's often because of the risk for infection. But if they need it, let's get it in so that we don't have any trauma. So if we're going to give this clot buster, we need to get all of these labs drawn before and Foley's in before we give that. So other treatments. Thrombectomy, this has become very common as well. They go to interventional radiology, IR, and they literally go in there with a catheter through the vessels and find the clot and pull it out. So that's fantastic, because that's the best way to do it, because I can put you on heparin to keep you from making new clots. I can give you a clot buster to try to break up the clot that's there. But the best thing is, let's just go get that clot out. Do remember, when they have this, and they come back to you and you're caring for them, they've been anticoagulated, so their blood's going to be thin. So that site that they've used, probably a groin site, you've got to monitor that for bleeding, bruising, because they will be thin. An IVC filter, inferior vena cava filter. So this is somebody with a lot of DVTs in their lower extremities. They put a filter in there to catch those so that they don't go to the heart. We do see IVC filters being put in prophylactically, if you want to think about it that way, for people who we know are going to be on bed rest. Maybe you've had a trauma and you have a broken pelvis. Well, you're not getting out of bed till we fix your pelvis, so put an IVC filter in you. Maybe you have a spinal cord injury. Those are just the couple of things that come off the top of my head. The other thing is lifestyle changes. What has caused you to have a DVT? Is it because you don't get up and move? Is it because you work from home, so you need to do things about getting up and moving? Or maybe you traveled and you didn't get up and you weren't hydrated, or you drove from Dallas all the way back to Amarillo, and it's 7 hours and you did not stop one time. You can certainly develop a DVT. I've heard of that happening. So those are the medications and things that we're going to give. So think about what that means and what you need to do. Certainly they're going to need IV fluid. They may need pain medicine and comfort because they're hurting. But once we open that, get rid of the clot and get some blood flow and oxygen to that lung, that pain should go away. All right, let's talk about our lifestyle. That says lifestyle, and that should say lifespan. And so I've already had to correct something on this, and y'all are just going to watch me do it right here. I've been thinking about cardiac and got lifestyle in my head and wrote lifestyle instead of lifespan. So let's talk about PEs in children and pregnant women. So, can children get PEs? They can. It is fairly rare. Um, their clinical manifestations are really tachycardia, tachypnea, chest pain, shortness of breath, cough. They don't tend to have hemoptysis. Um, and it's probably more kids getting treated for cancer or some kind of central line things like that. Um, Pregnant women, those symptoms are very similar to adults: shortness of breath, edema, tachycardia. Um, Sometimes it's a little more difficult to identify and diagnose this in pregnant women because those signs and symptoms are actually the same as just being pregnant. They will be treated with low molecular weight heparin, so enoxaparin um, could be used. They would use heparin closer to delivery because it has a shorter half-life. We can turn that heparin off, monitor their labs, get those coax studies back to normal if we need to deliver. They might get an IVC filter. Really, there's no difference in the older adult and the things that we just talked about. Okay, so let me do a little recap for you for PE. So PE, these are these can and are often life-threatening. So we need to be aware of that. Look at these clinical manifestations and think about what's going on with our patient. Biggest takeaways: what are the risk factors? Because you need to think about that. Risk factor: not moving, being immobile, having recent surgery. So if you work on a post-op floor or take care of a post-op patient or have a loved one or a neighbor who's a post-op patient, part of your instructions are they need to get up and walk and move around. What you may need to do, we don't want to scare people, but to say, we want you to get up and walk and move around so we've got blood flow, because you don't want to have blood flow staying in your legs and developing a clot and get complications. That's probably the easiest way to say it, because we don't want to say, oh, if you don't walk, then you're going to get a big clot. It's going to go to your lungs and you could die. That's a little crass, and there's a better way to say things like that. So work on those risks. So think about those risk factors, and really the best that we can do to prevent that. Look at your clinical manifestations, and as you go through that list, think of, what am I going to do as a nurse? As you review all of this, you've got to go through the nursing process. What health history questions do I ask? What is my focused physical assessment going to look like? How am I going, do I need to analyze? If I think my patient has a PE, they're going to go to radiology. They need a CTA. We need to get in there and we need to look. We need to look at lab work. And then I need to expect that my patient is getting some kind of anticoagulant or clot buster thrombolytic for this. They may also go to interventional radiology to have that clot removed so that we can get more blood supply. So give them some oxygen. Worst case scenario, we may have to intubate this patient and put them on a ventilator. Think of your treatments. We talked about kids. This is pretty rare in kids, so I don't think we're going to see it. We will see it in pregnant women. That always complicates things when I have a mother and a baby. Worst case scenario is if that woman is closer to term, you know, we might have to deliver that baby to be able to take care of the mom. So be sure you think about the nursing process, think about what your goals for these patients are going to be, what you're going to do, what interventions are you going to do, what assessments you need to do, and then how you evaluate your care and what you're going to do if you don't meet your goals of care. Thanks.